Hello and welcome. Our topic for today is tuberculosis and syphilis. It's two really important and two really difficult diseases of our course, and both of them characterized by granulomatous proliferative inflammation. The first disease which we will discuss today is TB or tuberculosis. Uh, Dynamic of TB infection is really dangerous nowadays, and we can see a lot of cases of TB infection in population. We can see that in 2000 year we can see increases of TB, and World Health Organization worried about TB spreading and cases of TB infections because it's really expensive course of treatment and really dangerous complications of this disease, and people with TB infection may be ill for 1.5 year, and all of this period it's impossible for them to have their work and do something else. On this slide you may see Mycobacterium tuberculosis. Mycobacterium tuberculosis is a etiological factor of TB infection. It spread in every place of the world, and you may see it in any continent, and it one of the specific characteristics of this infection, worldwide spreading. Uh, what is tuberculosis? You may see tuberculum in the name of this infection, and tuberculum means node. And the name of this infection associated with special anatomical manifestation with formation of tuberculum nodes. Uh, and I hope you remember from our class about proliferative inflammation and about granulomatous inflammation. The special name of special granuloma in TB is tuberculum node. And if you want to be a doctor who will treat patients with TB, you will be physiater. And physiology is a science about tuberculosis. So it's really difficult work and it's really interesting specialization. So I have already told you that TB characterized by some special reasons, special manifestations. We are prevalence everywhere or worldwide spreading. You may see TB infection on any continent. Duality of manifestation. In TB infection, we should separate disease and presence of mycobacteria in the organism because um, it's really important for our immune system and for our defense against TB is presence of mycobacteria in our organism. That's why all of us contain mycobacteria in our organism, but not of us are ill. The next characteristic is polymorphism of manifestations. And we will discuss today that TB has a lot of different forms, and all of them characterized by special anatomical manifestations. Chronic wave-like course, so it's just subscribe of course of this infection. We can see period of light and period of complications and rising of infection. On this slide we may see TB in the between the cells of organism. You may see with red spots in the histological slide. So I have already told you that there are a lot of different forms and different manifestation of TB infection, but also we should discuss the main forms of TB. They are primary, hematogenous, and secondary. All of them we will discuss today. Primary TB characterized by sensitization and allergic reactions in the organism. From immunological point of view, it's immediate hypertensive reaction, which characterized by predominance of exudative necrotic manifestation, but not only exudative necrotic, but also proliferative processes, and all of them we will discuss today. Tendency to hematogenic and lymphogenic generalization. It's really important for primary tuberculosis, hematogenic and lymphogenic generalization, but not bronchogenic. Paraspecific reactions in the form of vasculitis, arthritis, and serositis. We may see involving all organs and all systems in this pathological process. So, the next topic which we will discuss is ways of spreading the infection. Yes, the first association with TB infection is a lung disease. Yes, and it's true that aerogenous route is predominant. Something about 95% of all cases associated with infections of a lung and spreading by aerogenic route. But also we should remember about alimentary route and injury of intestine in case of TB, in primary TB, and about skin and conjunctiva injury. It also, unfortunately, it also may be. The typical anatomical manifestation of primary TB is primary tuberculosis complex, which consists of primary affect, lymphangitis, and lymphadenitis. Definition of all these terms you may see on this slide. Macroscopically, we can see primary TB effect here, primary tuberculosis complex here. It may localize in any organs, but mostly it will localize in the right one because of angle of right main bronch, and we can see a lot of air in the right lung, and it will lead to most typical localization of primary injury in the lung. One more photo will be the same process, and we may see this pathological process closer. On this slide, we may see manifestation of lymphadenitis. So we may see lymphatic node, and it is increased in size. And also we may see manifestation of some inflammatory and necrotic changes in it. So we may see area of caseous necrosis here. We can see overgrowing of lymphatic tissues and also increases in size. I hope you remember this slide from the proliferative inflammation topic, and on this slide we may see histological picture of tuberculum node. Tuberculum node is special granuloma which characterized by area of caseous necrosis, epithelioid cells, and cells of pyrogulin cancer. Pyrogulin cancer cell is specific cells, specific gigant cells which have symplast of nucleus, which localized in the periphery of cytoplasma in form of arc. And tuberculum node will have same anatomical structures in any cases of TB infection. In case of alimentary way of infection, we may see damage of intestinal primary, and it will consist of same tuberculosis complex. It will be primary affect, lymphadenitis, and lymphangitis, but we will localize in the intestinal. So all of these changes you may see in this slide. So we may see damage of mucous layer of the intestine and some changes in lymphoid follicles. Anatomically, we can see pictures like that. It's really important to understand that primary tuberculosis complex and primary TB at all may have different outcomes, which may be associated with healing, progression, and chronic course. Let's discuss all of these variants. Healing. Healing will develop stage by stage. It will be associated with changes in the primary effect, It may be associated with encapsulation. Encapsulation will be associated with development of connective tissue around the pathological process. Petrification and ossification will be associated with accumulation of calcium salts, and the mechanism of calcium salts accumulation is dystrophic calcification. I hope you remember it from mixed degeneration topic. Lymphangitis. It's changes in the lymphatic vessels, and in the lymphatic vessels we may see sclerosis only. In lymphadenitis and changes of lymphatic nodes, we may see sclerosis and petrification. Sclerosis is development of connective tissue, petrification associated with accumulation of calcium salts. In results of healing, we may see formation of Ghon complex. Ghon complex, it's a healing primary tuberculosis effect, and we may see it in this part of the slide. And in this slide, we may see different variants of primary tuberculosis complex or of Ghon complex, which we may see on macroscopically and which we may see under X-ray examination. And also on this slide we may see Ghon complex according to microscopical examination. Under light microscope it will look like overgrowing of connective tissue or accumulation of calcium salts. The next variant of outcome is progression. Progression may have different ways. It may be hematogenous, lymphogenous, and it may be associated with growth of the primary focus. In case of growth of primary focus, we may see development of caseous pneumonia and development of primary pulmonary cavity and formation of chronic course of TB. In case of lymphogenic dissemination of a process, we may see spreading from one group of lymphatic nodes to another, and again formation of chronic course. In case of hematogenic dissemination, we may see miliary and macrofocal TB. So, miliary TB, we can see a lot of miliary forms today, and all of them characterized by size of damage area, something about 5 or 3 millimeters. Macrofocal more than 1 centimeter. It's really important for it when you will make your diagnosis. All of manifestation of this form of TB you may see on these slides. Macrofocal, we may see formation of cavern here. Also, we may see miliary form, macrofocal form, and miliary TB in histological examination. On histological examination, we should pay attention for tuberculum nodes, its special granuloma. And we again may see all typical manifestation of granuloma in TB. Area of caseous necrosis, epithelioid cells, and cells of Pyrgova-Langerhans. You may see it in most of tuberculum nodes, but not in all. One more photo with tuberculum node, Pyrgova-Langerhans cell in the center, and I hope you can find it on the slide. One more photo with caseous pneumonia. We may see a big area of damage here, and in result of it we may see formation of acute caverna in the lung, and also unfortunately it will lead to death of the patient. On this slide we may see again formation of a caverna in the photo and in the scheme. The next form of TB is hematogenous tuberculosis, or second name of this infection is post-primary. The post-primary name associated with mechanism of its development. Hematogenous tuberculosis its development possible only post-primary, so you should have primary TB for development of hematogenous one. And it also has 3 forms. We are generalized, pulmonary hematogenous, and extrapulmonary hematogenous. Generalized form consists of special forms which are associated with acute tuberculosis sepsis, acute general miliary, and acute general large focus. Acute tuberculosis sepsis are associated with spreading of infection by blood flow, and it will be associated with formation of TB infections area in all organs and systems. Acute general miliary TB associated with formation of miliary TB injury in organs and characterized by its area of damage less than 5 millimeters. Acute general large focal will have same characteristics, but the size of the pathological focus will be more than 1 centimeter. On this slide, you may see schematically the image of organism in case of miliary TB and in case of large focal TB. Hematogenous tuberculosis with prevalence lesion of the lung or pulmonary form of hematogenous tuberculosis may manifestate itself by acute miliary tuberculosis of the lung, chronic miliary tuberculosis, and chronic macrofocal form. So the macroscopical manifestation will be same. For chronic miliary tuberculosis, we may see dissemination of area of damage, the area of damage in all surface of the lung. You may see these white dots and way localized in all surface of the lung. The size of each point less than 5 millimeters. In case of chronic miliary TB, we can see same anatomical picture, and but the difference will be in the consistent on this area. In case of chronic type of miliary TB, we can see more solid consistent of this focus. So different photo of this pathological process on this slide and this one. Chronic macrofocal TB associated with disseminated injury of the lung, but focus of the injury more than 1 centimeter. Extrapulmonary hematogenous TB associated with injury of bone and joint system, urogenital system, the endocrine system, skin, and all other organs, for example, the brain. On this slide, you may see injury in this place macroscopically, and histologically we can see some inflammatory changes in this area of the brain. On this slide, we may see injury of spine column, and we can see pathological fractures of vertebrae in this part of the slide, which is associated with overgrowing of caseous process, and it will lead to fracture in these places. And also you may see knee, and in the knee you may see some pathological process here and here, which are also associated with injury, with tuberculosis injury. Tuberculosis of the kidney is a really typical or common situation for TB infection. So you may see healthy kidney in this part of the slide, and some changes which are associated with TB in this pole of kidney here. One more slide about kidney injury in case of TB infection. So macroscopically it may look like that or that, and histologically you may see some inflammatory changes in the kidney tissues. The next main form of TB is secondary TB infection. Secondary TB infection may develop only after stopping of primary TB and it's typical for patients who heal after primary TB infection. And it characterized by pulmonary localization of the process, contact or intracanalicular progression, so bronchogenous type more typical for them, and change of blade morphological forms. The forms of secondary TB you may see on this slide, and it's really important to understand that forms of this type of TB are form phases. Uh, we called like form phases because they may lead to each other. So in any case, it starts from acute focal TB, and acute focal TB will lead to formation of abricosal focus, and it may be upper part of the right or left lung, and we may see acute inflammatory reaction in this localization. It should be first or second segment of the right lung, mostly right lung. And in the development of this infection, we may see formation of fibrous focal type of TB, and it will lead to formation of Ashol pool focus. Ashov pool focus looks like abricosal focus, but which surround by connective tissue, and sometimes they contain some calcium salts. In case of immune failure, we may see formation of infiltrative form of TB from both of these forms. And infiltrative TB characterized by big area of damage which involved something about one or two segments in the pathological process, and in case of strong immune response we may see formation of tuberculoma from infiltrative type, and in case of immune failure we may see a formation of acute cavernous or casus pneumonia after infiltrative TB. Tuberculoma. Tuberculoma is special type of secondary TB, which typical only for patient with strong immune system, and it characterized by formation of special solid masses in the lung, and it's one of the most favorable course of TB. The acute cavernous form of TB will lead to formation of cavities in the lung, and we will discuss them a bit later. And after tuberculoma, we may see caseous pneumonia, and after infiltrative TB, we may see caseous pneumonia. But after tuberculoma, caseous pneumonia may develop only if we may see suppression of immune system. And after acute cavernous TB, we can see formation of fibrous cavernous TB. Fibrous cavernous TB will looks like acute cavernous, but we can see some difference, which we will discuss a bit later. And in the end, we should remember about cirrhotic form of TB, which is associated with overgrowing of connective tissue in the inflammatory places. Let's discuss all of these forms a bit closer. Acute focal TB, characterized by abricosal focus in the upper part of lung. Mostly it will be right lung, and it is associated with right bronchus angle. And outcome may be encapsulation or petrification and formation of a focus of Ashov pool. We have already discussed it. Macroscopically, you may see acute focal TB here, and it will look like that. On this slide, we may see formation of Ashov pool focus, so we may see some inflammatory process and surrounding connective tissue or calcium salts and surrounding connective tissue. It's typical manifestation of Aschoff pool. For this area, we may see development of connective tissue in the periphery of it and a typical inflammatory process in the center. So we can see Pyrogov-Langhans cells and all other manifestation of TB infection. In development of TB infection, typical manifestation is a formation of archive of tuberculosis. And tuberculosis archive consists of Siemens focus, its area of reinfection, and area of saving of infection in the organism. Also, it will be Aschoff pool focus and Abrikosa focus, which we have already discussed. On this slide, we may see some tuberculosis archive. So, in autopsy, we should find changes like this in the lung, and in close examination, we may see all these focuses: Siemens focus, Aschoff pool, and Abrikosov. Fibrous focal TB, source of it is overgrowing and development of Aschoff pool focus. Morphologically, it will manifestate itself by new focus of caseous necrosis and scarred focus. On this slide, we may see schematically image of this pathological process. So we may see Aschoff pool focus here and a new focus of reactivation of infection here. Histologically, again, we should find all these typical manifestations like overgrowing of connective tissue. We may see inflammatory process and some typical inflammatory reactions. Aschoff pool focus schematically will looks like that. So we can see some inflammatory area in the center. We can see overgrowing of connective tissue which will surround it, and connective tissue in the lymphatic vessels. So you may see it here and here. Macroscopically, it looks like that. So fibrous focal TB will looks like acute focal TB, and difference between them will be associated with source of infection and consistent of pathological process, pathological area. The next form will be infiltrative TB. The source of infiltrative TB is progression of acute focal or exhibition of fibrous focal TB, and morphologically it characterized by focus infiltrate Assmann Riedeker. I will show you it on next slide. So you may see Assmann Riedeker focus here. The next form of TB is tuberculoma, and I have already told you that tuberculoma, one of the most favorable type of TB infection, because it's typical only for patients with huge immune system. I will show you macroscopical view of this pathological process, but you should remember about classification of tuberculomas. Tuberculomas may be infiltrative pneumonic, and it will consist of compound and depressed pulmonary tissue. Also, it may be caseoma, and in case of it, we may see connective tissue capsula, and in it we may see accumulation of caseous masses. And also, it may be tuberculoma of type with filled cavern. So we may see formation of caverna with accumulation of necrotic tissues. Macroscopically, tuberculoma looks like masses in the lung, their forms may be different, but more typical is round form of it, and we may see some masses in the center of it. Schematically, we can see depress of lung tissue, formation of connective tissue, and accumulation of caseous masses here. The next type of secondary TB is caseous pneumonia. Caseous pneumonia, one of the unfavorable course of TB infection, and in most cases it will lead to death of the patient. And it's really important to understand that it may be final stage of any forms of secondary TB, and it may be terminal stage and lead to death of this patient. Macroscopically, it's characterized by involving of lobe of the lung and development of caseous pneumonia in the lobe of the lung. So it will have really difficult complications, and for patient it's really dangerous. On this slide we may see schematically manifestation of it, and photo of patient with caseous pneumonia here. So it will lead to involving of big area of lung tissue and will lead to decrease of breathing surface of the lung. That's why it's really dangerous and may lead to death. One more photo with with a caseous pneumonia. After it, we should discuss acute cavernous TB. And it's really important to understand that acute caverna form stage by stage, and we may see the focus of caseous necrosis. After that, we may see purulent meltdown of necrotic tissues, decay, cavity, and acute caverna, formation of acute caverna in the end of it. On this slide, we may see schematically image of acute caverna here, and it's really important to understand that it may be not only one caverna, it may be a lot of them. The size of cavernas may be different, and the shape of them also may be different, but the main idea is formation of abnormal or pathological cavity in the lung. Fibrous cavernous TB develops after acute cavernous TB, and morphological substrate is chronic cavern. The difference is formation of connective tissue in the wall of cavern. According to size of caverna, we may see small, medium, large, and gigant cavernas in the lung. So I hope you can see the size of them on the slide. Macroscopically, fibrous cavernous TB looks like that. So we use special staining for connective tissue here. That's why the wall of this caverna are blue, but in normal condition they will be white or pink color. One more photo with chronic caverna here and here. Again, here and here. And difference between acute and chronic caverna, it's really important to understand the difference between them, and it will lead to different outcomes of these cavernas. So the wall of acute caverna consists of two layers like caseous necrosis and compacted lung tissues. Chronic caverna wall will consist of three layers: caseous necrosis, granulation fabric, and fibrous layer. The acute caverna we may treat without surgical treatment. So it's not necessary to make operation in case of acute caverna. But in case of chronic caverna, one of the typical method of treatment is surgical methods. Fibrous cavernous TB. On this slide we may see a lot of cavern with solid walls here in all area of the lung, and this form also associated with dramatically decreased breathing surface of the lung. One more photo with cavern. And in result of fibrous cavernous TB, we may see formation of cirrhotic form. And all other manifestation of cirrhotic form will be associated with chronic cavernous, pneumosclerosis, bronchiectasis, and pleural effusion. So on this slide we may see involving of one lobe in the pathological process, which will be associated with pneumosclerosis and formation of chronic caverns here. But also we can see overgrowing of connective tissue between lung tissue and pleura. We may see increase of bronch lumen size and so on. So it's all about tuberculosis. The next infection will be syphilis. I hope you remember and I hope you know about syphilis from other departments, and I hope you understand that syphilis is infection, sexual infection, and typical spreading of it is sexual contacts. And the etiological factor of it is Treponema pallidum, and you may see it on the slide. This treponema may injure all organs and systems and will lead to formation of stages of syphilis. And syphilis has some stages. They are primary, secondary, and tertiary, or late syphilis. Sometimes we talk about latent syphilis. Primary syphilis development in first 2 weeks after sexual contact. Secondary period starts from 4th week and till 6 months, maybe more, maybe 8 months. And tertiary period of syphilis will manifestate itself after 10 or 15 years after sexual contact. Sometimes it manifestates itself after 20 years. Primary syphilis. After sexual contact in first 2 weeks, we may see formation of primary syphilitic complex, which will consist of primary affect or solid chancre. I will show you solid chancres, and you should find them, and you should take this patient and send them to dermatologist or infectional doctor. The next component is lymphangitis and lymphadenitis. And we should pay more attention for solid chancre because it's a typical morphological manifestation of primary syphilis. Chancre characteristics you may see on this slide. It's indult, punched out appearance, indurated, and also it is painless, raised borders, red smooth base, scant serous secretion, and some of these components will protect our patient from the doctor, and it will lead to really big troubles with his health. One of the big problem is painless. The solid chancres looks like very disgusting, but they are not pain. They don't have pain essence. That's why patients don't go to the doctor, and it leads to big troubles. Oh, I should worry you about disgusting pictures on next slide, so be ready. On this slide, we may see typical localization of the solid chancres. So it will localize in the genital system, and it may be single, and sometimes they may be multiply chancres. And typical localization is genital tract. But sometimes it may localize not only genital tract. For example, it may localize on the fingers, tongue, and also in the teeth. So uh, that's why you may be not dermatovenerologist, but you may see patient with syphilis in your clinical practice. For example, for stomatologist, for otolaryngologist, for surgeons, and for stomatologist again. This patient may firstly come to you. And this atypical localization of solid chancres will associated with pain syndrome, and this patient will meet and they will ask for help. Secondary syphilis. Secondary syphilis develops after 6 or 8 months after infection, and it characterized by catarrhal inflammation on the mucous membrane, polyadenitis, and formation special rashes and special formation syphilids. You can see mistake here, not syphilis but syphilids. Syphilids. Uh, Macroscopically, rash in syphilis will looks like that, and it may localize not only the skin, uh, like this roseosa rash, it may localize not only the skin but also in the internal organs. And localization of this rash in the internal organs will lead to really big troubles. For example, it may lead to degenerative and necrotical process in this organ and will lead to some organs failure. And after secondary period of syphilis, we may see tertiary period. Tertiary period will manifestate itself something about 10, 15, or even 20 years after infection, and it characterized by chronic diffuse interstitial inflammation and formation of gumma from morphological point of view. It's the most important morphological manifestation, interstitial inflammation and formation of gumma. The manifestation of tertiary period of syphilis will be associated with clinical forms. And the typical forms are cardiovascular, neurosyphilis, and benign type of it. Cardiovascular type of syphilis will be associated with injury of big vessels like aorta, and we may see mesoarthritis and all other damage of vessels, which will be associated with damage of their wall, formation of aneurysm and their ruptures, and fatal bleeding. Neurosyphilis will be associated with formation of gummas in central neural system, in brain and spine cord, and may lead to some paresis, and all other derangement of innervation. On this slide, we may see gum of nose, and yeah, we should tell a few words about tertiary syphilis, tell more words about tertiary syphilis. In nowadays, it's really rare situation because we can see a lot of antibiotics in other scheme of treatment, and even we will treat the pneumonia, for example, we will treat syphilis also. That's why nowadays tertiary period of syphilis is really rare condition. Gumma of the lung, we may see it here, Guma of the liver, we may see it here, and also we can see border between guma and healthy tissues in the organism. You may see it here. A cardiovascular type of syphilis will be associated with damage of vessels wall, and we may see mesoarthritis. It's a special inflammatory reaction in the valves or wall of arteries, and it will lead to thickness of arterial wall and may lead to formation of aneurysma and valve rupture. So you may see it on these slides. Histologically, we can see para-inflammatory reaction around the vasa vasorum, of vessels. I hope you remember from anatomical course that we may see some special arteria in the wall of arteries for nutrition. So we may see inflammatory reaction in these arteries. Neurosyphilis. I have already told you about this form of disease, which is associated with formation of gumas in the central neural system. It may be associated with damage of brain and damage of spine cord. So you may see all information of this slide. I will not tell you again. Congenital syphilis. It's really dramatical situation when the mother in pregnancy may be infected by syphilis, or it may be infected before the pregnancy, and it will lead to some complications and really big troubles for fetus, because it may be associated with miscarriage and stillborn early, and also it may if newborn and fetus will survive, if newborn survive, it lead to early congenital system syphilis and large congenital syphilis. We will discuss all of these manifestations a bit later. Syphilis of stillbirths characterized by death of fetus in the 6th or 7th month of pregnancy. And the cause of this death is toxic effect of treponema. Early congenital syphilis will manifestate itself in first 2 months of life by white pneumonia, flint liver become gray color, syphilitic osteochondritis, and syphilitic meningitis. Late congenital syphilis manifestate itself by triad of Getchinson or Getchinson triad. Getchinson triad consists of deformity of teeth, parenchymal keratitis, and deafness, and it's really dramatical situation for patient and for its life, really difficult life condition. So thank you for your attention and goodbye.